Hey everyone, I'm Austin Chen. I'm one of the internal medicine chief residents at the Montlake site here. Thank you all for coming to Department of Medicine Grand Rounds. If you're on the Zoom and in the building, please try to make it in person if you can. Really trying to encourage in-person attendance, but also making sure it's accessible for other folks at other sites. But great to have you all here. It's in Turner Auditorium D209, if you're not sure where, in the Health Sciences building. But I'm really excited for all our speakers today. We have Dr. David Horn, who will be introducing them. I think many of you know him, but he is the Associate Chair for Diversity, Equity, and Inclusion in the Department of Medicine and a professor in the Division of Pulmonary, Critical Care, and Sleep Medicine. Thanks again for joining us today.
Thank you, Austin. So it is my distinct pleasure to introduce these three speakers today. So the Equity Academic Scholarship Award, or ESA, formerly known as the DADSA, has existed since 2021, and one of the key supporters of it, Bessie Young, is here in the audience today as well. So this is our fifth cohort of recipients. The ESA is meant to address one of the challenging career transitions, which is advancing from postdoctoral and fellowship positions to faculty positions. And the ESA provides partial salary support for 1 to 2 years at $50,000 per year to support this transition. This award is open to all applicants, and we encourage applicants from groups who are from historically marginalized and minoritized communities with disabilities or other life challenges, including applicants from disadvantaged backgrounds. So types of awards like ESA are needed now more than any time in recent history, when much of what I believe in is under assault by our national leadership, who seem blind to our common humanity. What is the alternative to curling up in a fetal position? These three ESA recipients are building community, working for change in their spheres of influence, and providing current leadership, which will grow with their careers. And just as importantly, who they are and what they are doing sends strong signals to trainees and future trainees that you can align your research or scholarly passions and your values to make difference. So I feel privileged to be in their presence at this point. I'll introduce each recipient as she or he is speaking. So first up is Dr. Justin Bullock, who every time I go to a talk, no matter what it is, the speaker, who is always from outside of Seattle, just brings up Justin's name. But he is an assistant professor in nephrology at the University of Washington School of Medicine and the co-director of the Docs with Disabilities Initiative. Dr. Bullock is passionate about creating safe environments in medicine where everyone in the hospital is able to bring their authentic selves to work in the spirit of healing. Dr. Bullock is also passionate, a medical educator, a teacher, researcher, and lifelong learner. His primary research focuses on how educators can foster identity, safety in the learning environment, where all patients and members of the healthcare team can be their authentic selves in the workplace. Justin?
Thank you very much. Let's see if I can move this. Okay, cool. Thank you. Thank you very much. Thank you everyone for coming. I am excited to share with you all some research near and dear to my heart. I'm in the Division of Nephrology. Thanks for all the nephrology folks who are here supporting. I'm also working on a PhD through Maastricht University in the Netherlands. And this project that I'm going to present, and really this sort of program of research, is all related to my PhD thesis. I guess just say a little bit about myself. I'm originally from Detroit. I am a washed up college athlete. I ran track in college. Sort of separate to and kind of addition to my research, I have bipolar disorder, and I do a lot of advocacy work related to that, both with the Docs with Disabilities Initiative and kind of otherwise. And my PhD work has been spent describing a construct called identity safety. And this paper, Numbers Ain't Neutral, a quant-crit analysis of the relationship among stereotype threat mitigation and identity safety, is one of those papers. Just to comment, I picked this paper, one, because I really like the title, and I really like the project. And this, hopefully, you'll understand the title as we go. So I have nothing to disclose. First, just want to say that I'm very much supported by a very rich and strong community. These are a mix of my UW nephrology research mentors and my PhD and Maastricht mentors. And yeah, are people who have been incredibly supportive of me and really helped me thrive since I've been at UW. So as an education researcher, I study the learning environment. One of the things, but I actually initially started studying assessment. And one of the things that becomes very clear is that the learning environment deeply influences performance. As we think about equity and equity in learning environment, a lot of times we focus on like our assessment practices, but even if we have a completely equitable assessment system that we, treat everyone fairly, assess everyone in a relatively equitable way, if there's inequities in the learning environment, we can never actually truly have equity in assessment or in assessment outcomes. And one example of this is something called stereotype threat. So stereotype threat is a very well described psychological phenomenon in which members of negatively stereotyped groups fear fulfilling those negative stereotypes about their group. And we became interested in stereotype threat because we did a study in 2019, which showed that medical student performance on their third-year core clerkships was inversely associated with stereotype threat. So as people had more stereotype threat, they got fewer honors. We then did a subsequent study which further characterized how stereotype threat existed in the learning environment. And basically what we saw was one of the mechanisms by which stereotype threat impairs performance is it increases learners' cognitive load. So cognitive load is basically, it describes our working memory, how we use our working memory to accomplish tasks. When there's distractor information that consumes our cognitive load, it decreases our working memory that we have to deal with the tasks that we have in front of us. And these findings were largely consistent with many, many studies which are done in a variety of educational contexts with a variety of identity groups. But as we were doing the stereotype threat work, when you do a lot of work on identity threats, it can begin to become very heavy and kind of sad. And we began to think about, what could an alternative future or alternative world look like, where instead of focusing on threat, we actually were describing safety. And this led us to another study in which we tried to describe the sort of experience of identity dynamics in the workplace. Most of the literature and most of the educational efforts around combating identity threats are really reactive efforts. So after a microaggression happens, how does a person respond to try to mitigate that? While those efforts are very important, we do not call them safety. So we use the term threat mitigation to refer to reactive interventions after an identity threat. And separately, we describe this construct of identity safety. Before this study, the term identity safety, it exists in the literature, but it's very heterogeneously used. There are some people who would describe what we call threat mitigation as identity safety, which we disagree with. And there was one small body of literature that came from early education talking about identity safety, exploring identity safety. And one of the main features that came from identity safety, as they described it, was described the way that teachers drew on the cultural capital and cultural wealth of the students in their classrooms. And this was a very foundational sort of thinking that was influencing the way we thought about identity safety. The one other thing that I'd say is psychological safety is probably a form of safety that most people have heard of. Psychological safety focuses on hierarchy and says that when we don't attend to hierarchy, when people are afraid of violating the hierarchy, They are less likely to disclose errors. They don't speak up and challenge their leaders. They don't share their thoughts or opinions. And while psychological safety is a very useful paradigm, it's a very much downward flowing power. So it's usually described that the boss or the supervisor is the person who makes the people below them feel safe. In contrast, for us with identity safety, there's within the individual pillar, an interpersonal pillar, and a structural pillar. Within individuals, identity safety is fostered when people have the opportunity to leverage their own identities, their own cultural capital in the service of patients. So that could be things like through language concordance, through having experiential concordance, through having a family member who had a certain identity or experience and using that to help the patients they serve. And in this way, there are some times where the most junior person on the team can leverage capital or leverage power in ways that other people can't. Our interpersonal pillar is something called upholding personhood, where we make a person feel seen, that we value their identities, we value them sort of as a whole individual, and not minimize or tokenize a single aspect of their identity. And finally, belonging, which we use the definition of belonging, where a person feels free, where a person feels welcome to be their authentic self into a space, as opposed to a form of belonging where I am similar to those people who are around me. So this all led into this study, which I'm telling you all about. This was a study, we did a study of a national study of nephrology fellows. Nephrology is a very, very fascinating place to do identity research because it's actually one of the most diverse internal medicine subspecialties, has a very high number of what we classically call underrepresented minorities, and also of international medical graduates. And the nephrology, within the nephrology in training exam, the national exam that everyone takes while they're in fellowship, there's an educational opportunity to have a survey on the end of the nephrology training exam. So we wanted to take an opportunity to test our model of identity dynamics in a national sample of nephrology fellows. And so so that was aim number one. The second aim is to introduce a construct called QuantCrit. QuantCrit essentially is taking critical race theory and applying it to statistics or quantitative methodologies. Most people, when they think about critical race theory, apply it to qualitative methodologies. And I'll talk just a bit more about this. So QuantCrit believes that numbers ain't neutral, that statistics don't speak for themselves, and that quantitative researchers, despite the guise of appearing to be objective, make subjective decisions about their analyses that deeply influence the quantitative outcomes that we get from studies. This study, we designed a survey. We use a method called confirmatory factor analysis, which is a way to provide statistical validity data supporting the survey, and then compared what we call a conventional analysis to a QuantCrit analysis. So we had 8 items based on this educational opportunity. We wrote 3 for identity threat, specifically stereotype threat, 2 for threat mitigation, and 3 for identity safety. This is obviously a busy slide, but use it to say we had a 67% response rate amongst all the fellows nationally. And the demographics are largely representative of the nephrology fellow as an entire pool. I'm happy to, during the questions, everyone has questions about factor analysis, go more deeply into this. But we tested various models, and essentially the model that performed the best was a 3-factor model, with 1 factor being stereotype threat, 1 factor being threat mitigation, and 1 factor being identity safety. But importantly, there was the item that represent the agency to serve, or the way that people drew on their own identities. It did not load well onto the identity safety factor, and so we therefore dropped that term. So essentially, we analyzed using 7 of the 8 questions that we had. This figure in the bottom right is supposed to represent it represents the mean of the items that compose each factor. And what you see here is that there are 3 distinct distributions, which we use to further argue that these are distinct constructs that we're capturing, distinct statistical constructs that we're, and latent or actual constructs that we're measuring. So in the conventional analysis, the aim was to have as narrow confidence intervals as possible and as small p-values as possible. So we have aggregated groups. You can see that identity safety and the outcome is stereotype threat, with the reference group being white US MD students. That identity safety is inversely associated with stereotype threat, which fits our theoretical conceptualization in the qualitative data. But you'll also see that threat mitigation or reactive efforts is positively associated with stereotype threat. I would provide at least two potential interpretations. One, you could say that threat mitigation efforts, which we've historically used to combat identity threats, may not be the best thing to actually combat identity threats. Or you could say that folks who are having, if people are having to respond to identity threats, then those same people are also more likely to have higher stereotype threat. The quant crit analysis, one, it had consistent findings that identity safety was inversely associated with stereotype threat and threat mitigation positively associated with stereotype threat. But when we disaggregated the Asian group into East Asian, South Asian, Southeast Asian, and the IMG group into IMG based on country, we see actually a lot of interesting identity differences, which largely fit what we would have predicted sort of conceptually before the study. So you see that Southeast Asian, Black, IMG Asian, and IMG Middle Eastern students have higher stereotype threats compared to the reference group, which is a white US MD student. And also we have this interaction term, which I'll explain as, so Black and Asian individuals who trained in countries in which their racial group was in the dominant group, so Black individuals who were IMG Africa or Asian individuals who were IMG Asian, had less stereotype threat than their respective counterparts in the Asian and Black in the United States who trained in US medical schools. We use all this to say, and I guess I didn't put this data up, but basically also we looked at the agency to serve term, and Black and Latinx individuals had the highest scores on agency to serve, which again is consistent with the US demographics, that those individuals may be the most likely to have opportunities to sort of have leverage their identity capital in the learning environment, because those two racial and ethnic groups are the two most prominent in the US. We would say that this study supports the fact that identity safety appears like it may be promising as educators strive to optimize learning environments for diverse learners. There's a very large body of literature that says that stereotype threat is inversely associated with performance. And so if identity safety is inversely associated with stereotype threat, one could theorize that identity safety may lead to improved performance. There was some performance data that I tried very, very, very hard to get from the ASN, our national body, and basically, unfortunately, would not be able to get. But we'll continue to hopefully get that data. And second, a quant crit analysis provided insights into intergroup differences that a conventional analysis did not. And obviously limitations. I would say the biggest is that we were limited to 8 items. We are very early in our understanding of identity safety, and this survey most certainly will not represent our final sort of representation of the identity safety construct. So the next steps in my last 20 seconds is we did a qualitative study of identity safety in people with HIV, which is very fascinating. But I would say the biggest thing that came from that is we use the definition that identity safety is safety to be one's authentic self. But one's authentic self is a very dynamic construct. The authentic Justin in the hospital is not the same authentic Justin when I'm at a gay bar with my partner. There are some people in the study which showed there are some people who around their personal life prefer to share aspects of themselves with their providers and other individuals, and other people who are private. And what a sharing person wants for safety versus what a private person wants for safety is different. Another study, which we had a small grant from the nephrology division, which helped to pay for, is a longitudinal study following fellows throughout the duration of fellowship, with some very interesting findings that are more to come. And obviously, many of my collaborators are here in the audience. So thank you very much for listening. Welcome any questions. Yes.
That was really interesting, Justin. You mentioned that nephrology is one of the more diverse subspecialties. And how do you think that that might play into how trainees and people coming in are able then to find a place or a sense of belonging if they are more likely to have mentors and senior people who are also from this more diverse population of people? Like, do you think if you looked at another subspecialty, you would see that it plays out a little bit differently?
It's a good question. So obviously this is my theorizing, and but in other contexts, it's pretty consistently shown that there is certainly a benefit from like presence of numbers of people who share some aspect of your identity, and there's often, and there's also this concept of like a critical mass that you need a certain number of people, maybe not just one or two people to be enough. I would like to believe that nephrology is maybe a more hospitable environment for individuals, but I guess I would say from our longitudinal data, for which we had a few students who are IMGs, there certainly are many challenges, and that study was not just nephrology, but there are many challenges for instance, for being an IMG, and oftentimes some people would say that the programs which disproportionately attract IMGs often take advantage of those and have their structures in place that take advantage of those individuals. And so all that to say, one thing about the identity safety work, which we try to which our data sort of would say, is that there's an overwhelmingly usually when we talk about creating identity safe environments, we think that like identity concordance is one of the main, if not like, it's like the dominant thing that leads to safety. And we have many examples of when that was not the case. But obviously also we have many examples of when that is the case as well. So.
Oh, I think we have time for one more. One more, and there's also one on the Zoom, but we can just do one first. Yeah.
Hey, Justin, thanks a lot for this presentation. Obviously, you're looking at a very highly trained, highly educated cohort of folks, minoritized folks, but there are a lot of people that haven't persevered through all the structural barriers to even get to nephrology fellowship. Do you think that you might study identity safety in other populations earlier on education or training?
Yeah, so yeah, so some of the work has been in medical students, but even obviously medical students are at a point in which they sort of academically made it in some ways. I guess I would say the identity safety constructs seem to be quite consistent for patients who are not healthcare professionals. And so for instance, like some things that came from our patients, like folks with HIV, they talked about how they would disclose their status when they were getting their blood drawn to protect the people who were, who were serving them. But they also talked about other ways that, so one of the things with this construct that will evolve through time is we use the term agency to serve because, physicians or physician training are in a service profession, but there are many ways that people use agency that are not in service of other people. And this signal was very, oftentimes in service of oneself. So for instance, like folks with our patients, like some of the ways they exhibited agency was how they like asked, they would ask for providers who had a certain identity. They would give feedback to their providers, like you're speaking too loud, like so that everyone else in the clinic can hear, like you talk about, what's going on with me, et cetera, et cetera, et cetera. And so we think that this construct holds. And yeah. Thank you.
For our second ISA recipient, we have Dr. Tijana Milinic. Dr. Milinic is an acting assistant professor and physician scientist in the Division of Pulmonary Critical Care and Sleep Medicine. She specializes in the care of individuals with cystic fibrosis and those undergoing lung transplantation. Her research work focuses on advancing equity in cystic fibrosis care by addressing the systemic barriers that affect health outcomes for historically marginalized populations. And to do this, she uses both quantitative and qualitative methods to understand barriers to access. Her current work aims to develop an intervention to promote equitable clinical trial enrollment. Dr. Milinic.
Hey, thank you so much for coming, and I'm very grateful to be here. And I want to take the opportunity today to give you a broad overview of the work that I'm doing to understand equity and access to CF clinical trials. I have no disclosures. I was born in Mostar, former Yugoslavia, a country that doesn't exist anymore. I came to the US as a refugee in the late 90s. I grew up in Phoenix and spent all of my time on the west side of the country, most recently in Denver for residency, and I came here for fellowship, and I'm grateful to get to stay on as faculty in the Division of Pulmonary Critical Care and Sleep Medicine. So I am a CF and lung transplant pulmonologist. I spend some time in the ICU, and my research interests really center around the idea of using both quantitative and qualitative methods to evaluate and address disparities. And I'm also moving into the space of community-engaged research and clinical trials. These are my wonderful mentors, led by Dr. Kathy Ramos, who's my primary mentor. So I want to start out by giving you an overview and understanding of the cystic fibrosis population. So we know that CF is a genetic multisystem disease that affects other organs aside from the lungs. And we think that it affects 40,000 people in the United States. Contrary to widely held misconceptions, CF is a disease that affects minoritized people. So these are estimates from the 2024 CF patient registry. And we know that over 10% of people with CF are Hispanic and over 3.3% are Black or African American. Now, that's growing, and that's really owing to better screening, better newborn screening methods, and also just better recognizing that the disease exists in these minoritized communities. And so in 2024, the people being diagnosed with CF, 23% of them were of a minoritized race or ethnicity. Now, despite being a substantial portion of the population, Black and Hispanic people experience a greater burden of worse health outcomes. So things like lower lung function. Hispanic people with CF have a higher incidence of Pseudomonas infection and even experience higher mortality. Now, in recent years, people with CF have had substantially improving health outcomes, and that's really owed largely to the advent of CFTR modulator therapies. And those therapies correct the function of the CFTR protein. Now, not everybody is eligible for those modulator therapies based on their CF mutation. And importantly, we know that Black or African American and Hispanic people are less likely to have mutations that are eligible for modulators, 70% and 76% respectively. And that's compared to over 90% of the non-Hispanic white population. And adding to this, despite the greater burden of worse health outcomes, we also know based on a study done in 2016 that 25% of CF pharmacology trials reporting race and ethnicity had no minoritized people with CF included. We also know that trial participants are more likely to be white and to have private insurance. So with this history forms really the foundation of the overall focus of my work, which is how can we improve access to clinical research for all people with CF? And today I want to take the opportunity to give you a broad overview of both the quantitative and the qualitative methods that we're using to do that. So we start by understanding who's left out, what are the patterns, so where and why these inequities exist. And then we want to move towards co-creating solutions by understanding the experience of the people, the barriers that they experience, and then what solutions may look like. So I want to give you a flavor of what we're doing to understand the gaps. And this is measuring inequity in trial enrollment. So the ultimate goal we're trying to achieve is to compare study participation rate by race and ethnicity. And here we're comparing to the historically over-included group, which are non-Hispanic white persons with CF. So we did this by combining data from 4 large multi-center observational studies in CF. And we linked that data with CF Foundation Patient Registry, which gives us information about over 85% of people with CF in the United States. So we use that to identify people who were eligible based on inclusion criteria at the same sites that studies were being done during the same time frames that studies were being done, and who didn't participate. So we essentially identified people who were eligible non-participants. And so what we're doing is comparing enrollees to non-enrollees by race and ethnicity. And we built directed acyclic graphs with critical race theory in mind to really think about how these separate demographic, clinical, and social factors all interplay together and how we can use this data. And so we adjusted for other things that were important in clinical trial participation. But essentially what we're doing is trying to isolate the effect of race and ethnicity here and the experience of racism, therefore. So we use propensity scores and inverse probability weighting to adjust for confounding. And I want to give you the highlights. So essentially what we found was Black and Hispanic people with CF were less likely to be enrolled. And the numbers are stark. So this is an example of one study where we found a 67% lower enrollment rate among Black persons with CF, and that was statistically significant. Similarly, we found that there was a 34% lower enrollment rate among Hispanic people with CF, and that was also statistically significant. And now we're trying to answer the question of where do these inequities happen? So what we found was that these effects were more pronounced among sites with smaller proportions. So not just absolute numbers, but smaller proportions of Black and Hispanic people with CF. So we found there's evidence for that trials are not representative, but I want to tell you what we're doing so far to understand the mechanisms and the experience of minoritized people in studies and what are the barriers. So we're doing this through qualitative interviews, and we interviewed Black and Hispanic and Latina people with CF. And what we're trying to understand was experience and overall perceptions of clinical studies, as well as the things that make it harder and easier to participate. And we also wanted to understand how other social determinants of health impacted study participation. And finally, we explored solutions with our participants. So we recruited adults with CF from across the country at these various centers, and we also recruited through a CF partner organization called Community Voice. We ultimately did 20 interviews and analyzed those interviews through thematic analysis, and 10 participants self-identified as African American or Black, and 11 participants self-identified as Hispanic or Latina. So I'm going to give you a few examples of only some of the themes that we're finding, because there's many of them, and I would love to talk about actually all of them, but these are a few especially pertinent to the CF population. So as you recall, CF disease is a rare disease. There's not many people in the US with CF, and even fewer who are of a minoritized background. And participants described the experience of being a minority within a minority within a minority. There weren't other people who had CF in their communities at home. And similarly, people at their centers didn't look like them. And there was a lack of people of color who were other patients and other providers. And this was even more pronounced at those sites that had fewer of people of those communities, kind of referencing back to some of our quantitative findings as well. One participant said, "You don't want to be the only one there that's African American. You'd like to be able to talk to other African Americans that maybe experience some of the same things that you experience." Another said, "When I see them all, they're all white. None of them look like me. So that's really hard." And I also want to outline that this may affect not just CF, but other rare diseases where there are small numbers of patients. Another theme was that of racialized experiences and how that intersects with trust and how that may affect something like clinical trial participation. So people continue to have personal and vicarious experiences of racism, bias, and discrimination. And that affects their willingness to participate in something as vulnerable as clinical trial participation, which confers at least some amount of risk. People talked about these experiences also being everyday and commonplace. And one participant said, when I look at clinic notes, they'll say something like healthy, intelligent. And I wonder if someone else was here, someone that looked different, would you say intelligent? And people talked about trust being a two-way street. It's not just patient to provider, it's also provider to patient, and it feeds back on each other. And patients sensed a lack of trust from their providers. And this was especially people who weren't in the CF clinic, so potentially in the emergency room or in the hospital where they weren't as aware of CF disease. And they talked about providers even doubting their CF diagnosis in general. And that lack of trust and made patients not want to trust their doctors and the system. One participant said, well, I've had experiences where I was admitted and I had a doctor look at my chart and say, oh, you have CF, but you're not white. So I didn't want him to treat me anymore. And finally, experiences depend on communities and lived and someone's own lived experience and identity. And so participants from Hispanic and Latino backgrounds had different responses. One participant said, in Latino families, we've been brought up to not share personal information or to be careful what you say in front of professionals because they could take you away. And I think this is really important in today's environment where people were genuinely afraid of deportation. And they talked about coming to a study center and being worried about giving more people their personal information. And clinical trials, some of them actually require a social security number to get compensation. And so people talked about fear, especially nowadays. And finally, one theme was transparency about a history of research. Participants were very well aware of a history of unethical trial conduct in the United States. But something novel about our conversations was that people didn't want us to just hide that under the rug. They wanted us to talk about these histories and be fully transparent and acknowledge those histories. And they wanted actually us to outright ask people what your reservations are. So from the very beginning, ask why, what hesitations are, what the barriers are, and potentially what the reasons are for not wanting to participate. One participant said, I think really asking folks what makes you not want to participate and finding out those answers and starting from there. So those were some of the barriers among many, but we also explored solutions and they came into two large buckets. One of those buckets were information needs, and that includes who we're asking, how we're asking them, and the tools we're using to provide information. People talked about, and this sounds obvious, but approaching everybody, which is actually something we don't historically do because we tend to choose people in clinics who have a history of otherwise participating in research already. And so people talked about just asking all those eligible in universal screening and pre-screening protocols. They didn't call them that, but they were like, just ask everyone. The next solution was asking why people decline and recording those responses so that you can address those barriers and then reapproach people who otherwise had barriers to participation. People talked about having their doctor introduce the study first, someone who's trusted to tell them about research prior to approach from research staff. And finally, these last two are really tools that we could use. Virtual study visits help people who are otherwise geographically constrained gain access to studies. But people talked about having an online platform that includes reminders or messages from study staff. They also discussed audio and video content as being a way of giving information about studies that didn't use complicated consent language, for example, or complicated language in study forms. And then finally, the last bucket were support and community needs, or support and community. People discussed having a study contact who was available to answer study questions. And this is a really big one, having the opportunity to interact with others also participating in research. So you can build, especially in CF disease where there's not a lot of people in the community, you can build a sense of community among participants. And that addressed that theme of isolation. They talked about trial personnel who were culturally competent. And then finally, just doing more research to understand the experiences of Black, Hispanic, Latino, Latina people with CF. So we started by describing inequities and really evaluating where these equities exist, how they manifest. We did these interviews to start to understand what a tool or an intervention could look like and what are the things that the community needs in the tool. And now we're building towards creating those solutions. So with the support of the CFF Schwachman Award, we're also starting to co-develop an intervention. And we're doing an iterative series of focus groups to understand and build a tool. And that's a process called human-centered design. And so our ultimate goal is to test those solutions. And I want to thank you and thank the Department of Medicine for the ESA award.
Get time for one question when we get back.
I'll ask a question. Thank you for that wonderful talk. I just had a question about maybe this is for the Black participants. Did they report any sort of not reverse racism, but isolation from their own communities because they had a disease that wasn't very, present in Black communities, for example?
Yep, absolutely. People talked about not being understood by even their family and having to explain to their family multiple times kind of what their disease entails and feeling the burden of that and then coming to clinic and not having people understand that burden either. So absolutely, that was definitely prevalent.
Thank you.
Thank you. And for our final ESA recipient today, we have Dr. Khai Tram. Dr. Tram is an infectious disease physician scientist and acting instructor in the Department of Medicine within the Division of Allergy and Infectious Diseases. He conducts research on HIV and TB and practices medicine at Harborview Medical Center and UW Medical Center. At the former, he's a part of the Madison HIV Clinic. Dr. Tram attended Stanford University Medical School and completed internal medicine residency at Washington University in St. Louis, and then came here to UW to complete infectious diseases fellowship. He's dedicated a focus on using the tools of epidemiology, geospatial analysis, and infectious disease modeling to optimize public health interventions, particularly for TB and HIV. And he has an active research collaborations in Kenya and South Africa, and a special research interest in spatial and mobility data. Khai?
All right, I think I have 17 minutes, so I'll try to use all 17 minutes. But my name is Khai. I'm in the Division of Allergy and Infectious Diseases. I'm going to talk about mobility data and population health. Maybe this will be new for some of you all. This is an exploration of TB, mobility, and activity spaces. And thanks for having me. I have no disclosures, just an outline. I'll run through some background. I'll talk about myself for a brief second, discuss what I mean by mobility, present a research agenda, and then talk a little bit about TB control and some knowledge gaps, and then my project. So I won't belabor this slide, but here's where I did my training. I've had previous positions working in South Africa and in Washington, D.C. Probably most salient here is I worked in Uganda in 2016 as a Doris Duke Fellow, and that was with this. The SEARCH trial was a large community randomized control trial looking at universal test and treat for HIV. It was a really sort of formative project for me. We looked at TB preventive therapy, was able to be very productive during that time, looking at the TB care cascade in Eastern Africa. So that's Uganda and Kenya. But we'll just jump right into mobility. So what do I mean by this concept? You know, it's the geographic movement of individuals or populations It can occur across many different scales of distance or time. Some people are more mobile than others. You might think of truckers or nomadic tribesmen as always mobile. Maybe some people, like students, are only mobile some of the time. And then there's just the daily short-term mobility that all of us experience through our everyday lives. And how does this relate to infectious diseases? Well, people who are mobile might have sort of lower access to care, and they may have poorer outcomes in terms of treatment adherence, care engagement. They may be lost to follow-up, so to speak. They may also have greater exposures to certain infectious diseases. So within HIV, we found that people with higher mobility might have higher rates of HIV incidence. Within TB, there's been implications of mobility with the dispersal and emergence of sort of drug-resistant TB, and this is especially in South Africa. So Dave mentioned that I had a great interest in geospatial analysis, and I love maps and satellite imagery and all of that. So this is New Orleans, my hometown. But I've been thinking a lot about how to develop a mobility framework to inform public health action. I'll tell you what I mean by that. So defining measures of human mobility, there are different data sources. You might ask people through surveys where they went, measure their mobility through GPS or smartphones. And these can occur at different levels. You can look at population mobility, giant cell phone networks can tell you what people move about. You can do surveys, census, and then down to the individual level mobility measured through GPS devices. How would mobility influence infectious diseases or transmission dynamics? You might imagine that people may be in contact with greater numbers of people if they're mobile. They may have greater exposures. How does this inform sort of the epidemiology of HIV and TB? And lastly, what can we do about it? I mean, mobility is intrinsic to the human experience. All of us, most of us are mobile. And so what are the policy actions that can help support people who experience mobility? I'll talk about sort of some current research projects I have going on, TB and mobility in Kenya, which is the topic of this talk. But also I looked at HIV and mobility in rural KZN and Cape Town, and then sort of modeling to inform public health decision making. But today, just the first. So TB control. There's about 3 to 4 million people each year who develop TB disease, but who are not diagnosed or otherwise notified. This is the case detection gap. The WHO actually recommends community-wide systematic screening for TB in high burden TB settings. But large-scale case-finding trials have really had mixed effectiveness. These are trials in Zambia, South Africa, Kenya, and Vietnam with sort of mixed results. And so I've really identified 2 specific challenges, I think, in designing case-finding interventions for TB. One being, who are the priority groups that you would want to target? Secondly, where should these activities be deployed in the community? Just a quick review of passive versus active case finding. In the setting of TB, passive case finding would be someone who feels sick and then presents to a clinic or a hospital and is screened and diagnosed in that setting. This is in contrast to active case finding, where you go out into the community, you do screening activities and interventions to try to find maybe one particular person who has TB. And this is sort of outside the health facility setting. So active case finding, I mentioned 2 problems, the first being priority groups. So it would be logical to go after groups known to have high TB prevalence. So you think about household and close contacts of indexed TB patients, people living with HIV, for example, people who are incarcerated, and then people who might have structural risk factors for TB. So maybe people who live in urban areas, who have lower SCS. And to this, I would also add maybe mobile individuals as well might be a priority group that you want to target for the reasons I mentioned before. And there are some benefits, I think, to sort of targeting your case finding activities. You can identify populations of high prevalence, then you can screen fewer people, and then you have fewer false positives, fewer people needing interventions that aren't indicated, and then you can focus your limited resources in certain areas if you know where they are. Okay, so back to the satellites. So this is Nairobi. I was very fortunate to work with Dave on a TB prevalence survey in 2022, and we found an overall weighted prevalence of 806 cases per 100,000 folks in Nairobi. And here it is broken down by demographics, but you can see men had a higher TB prevalence, and then also higher or older age groups as well. So these might be populations you might want to target for TB active case finding. The second problem is, where would you actually do this? Where would you do your TB community screenings? This is a big city. So where do you target activities? So zooming in on Congo Soweto, which is in the northeast corner, this is an informal settlement. It has a higher TB prevalence than the citywide prevalence. So, you know, this is lots of shacks and informal housing. How would you know where to go if you're trying to find folks with TB that you can screen and help? So I'm just using this for illustrative purposes, but imagine that these yellow dots, I'm not sure if you can see, those are people with undiagnosed TB. Okay, so this person lives close enough to the Kahala Health Clinic. They feel sick, they can get diagnosed in this clinic, that's fine. But maybe this person doesn't feel sick, they just go to work, to the market, maybe they go to the bar on the weekends, this person goes to work, church, this person goes to work in the bar. This individual only goes to the bar, and this person never leaves the house. So logically, maybe if you're trying to find specific populations, you would find their activity spaces where they spend their time. So this is a bar, what I call a social activity space, but there are other ones as well. You can think about the home, work, market, other settings as well. So these might be potential avenues or venues where you could do your case finding activities. This concept of an activity space is where a person spends their waking hours outside the house. So I was inspired by Zumi and all. They did this study in Tokyo in 2003, 2011, looking at the activity spaces of patients with confirmed TB. They identified this railroad station with a TB patient density that was far higher than the average across the city. So this would be a logical place to do your targeting. So some questions that came up for me: are there specific mobility patterns associated with TB? And then are there activity spaces associated with TB? So I was able to leverage this prevalence survey I mentioned that I worked on with Dave. I won't go over the whole survey, but the idea was to understand and measure the prevalence of confirmed TB among the adult population in Nairobi across these 9 clusters. And so this was nested within a larger study, and I was able to add some questions related to mobility to the household questionnaire. We asked about daily mobility, their work commute, et cetera. Short-term mobility, how many nights they spend outside of their house in the last month, for example, and then also about their activity spaces. And so we were testing a couple hypotheses. Firstly, if people with greater geographic mobility, if that was associated with TB. Secondly, if there were activity spaces that were more so associated with active TB. We presented this or published on it already, but I'll show some tables here. So this is the work commute survey, but essentially found that most people walk to work. A lot of people did use the bus or taxi. Women were more likely to walk and less likely to use the bus. Young people used the bus more than older people. And the median commute distance was about 2 kilometers, but it was different between men and women. And so these are sort of mobility patterns. And then now looking at activity spaces. Activity spaces sort of varied across demographics. But overall, a lot of people spend time at home for obvious reasons, but they also went to school and work. And these are categories that I manually coded from the responses that we got. But the interesting part is that the activity spaces really differed by community. So each of these 9 grids represent a different cluster, and men are on the left and women are on the right. So this is the #1 report activity space. So a lot of people said home or work. But if you dig in deeper and ask for the second activity space, then you would find that this varied a lot by community, by demographic. So the brown bars would be social community spaces, and that was reported a lot in this community. For example, among men, was women were more likely to spend their time in markets. So how does this relate to TB? Well, in both the unadjusted and adjusted analysis, it seemed that older age groups, being male and reporting a social activity space, was highly associated with TB, an active TB diagnosis per the prevalence survey. So our first hypothesis, we didn't find mobility patterns that were significantly associated, but we did find that social activity spaces were associated with active TB in our study. So some preliminary conclusions we can draw, where there's some measurement errors or sampling bias that limited us in terms of finding an association between mobility and TB, perhaps? And then what are the actual social activity spaces that were most significant? Were they bars, clubs, gaming venues, et cetera? Can we identify those particular venues? We might need some more granular data for that. And then this concept of the spatially targeted active case finding, we would need more epi data to support who, what, where, when, and how to answer those questions. Happy to report now, can actually answer these questions with my next steps being a recently awarded K Award. So advancing, this work through 3 aims: prospectively gathering data on activity spaces for TB cases and controls for about 600 patients via survey and then GPS loggers. Secondly, using spatial techniques to map TB burden across different communities in Nairobi. Thirdly, to model this using an agent-based or individual-based model. And then hopefully an R01 down the road to really test out a spatially targeted intervention. Okay, cool. I want to thank my team, Jen Ross, my primary mentor, Dave Horn here, other people at UW, and then my mentors at Kemry, Videlis, Jane Ngongo, and Lillian as well. My email is there, peer evaluation, and I'll just stop there.
I have a question. I was curious, like with the Japanese study,
Yeah.
how was it determined, like the density of TB, say in that station, and just generally, how is that determined? That
Yeah, we
high
can go
burden
back to that
access
slide.
spaces?
Sure, the Izumi study, I believe, they looked back at their records and they followed up with several hundred people who were diagnosed with TB over that time period, and they went back and asked them their activity spaces. So they asked them their top 4 spaces that they spent time in within their working hours. And then from that, they mapped through a grid TB cases to certain grid cells across the area. So, but I think you're referring to this map. So this is kind of the impetus for thinking, is there a place we can spatially target within certain neighborhoods? Is there a venue, a bar, a social activity space, which would be highest yield for case finding for TB? And can we sort of rank order these things? Can we provide this to a TB program to use? Justin.
It's a related question, but are there I'm thinking back to during the COVID pandemic where opera singers were getting COVID from are there any I guess where do you what spaces do you think will be the hot spaces?
From our preliminary data, I think that the social activity spaces, so bars, would be a really great place to screen. The thing is, I don't know if people want to be screened for TB when they're out for drinks. So that'll be another sort of implementation kind of study and patient preference. But I think crowded social places would be a place where certain demographics who had a high risk of TB would be found outside of the home. Cool. Well, thanks very much.
Thank you. We are at the end of time. A final round of applause for our more than deserving ESA recipients. We should all be proud of them. So thank you.